In April of this year, the Association of American Medical Colleges published a paper. They speculated that by the year 2030, we were going to see a potential of 121,000 physician shortage. Just take a moment to consider that. What's that going to look like? In an environment where providers are already at increased rates of burnout, can we really ask our providers to work more hours or delay retirement by up to 2 years? These are scenarios that the AAMC actually worked into their scenarios in their paper. Unless we get a bunch of volunteers to do those two things, we really need to figure out how we're going to meet this demand. So a good place to start is probably training more physicians. It's a great start. That is not the button.
Push it again. Left and right.
Left and right. Hey, good to know. All right, so in the black and white part of this image here, this is from the AAMC paper. I added some pretty little colors in here. What they did is they worked out the 75th percentile and the 25th percentile of their numbers. That's how they kind of worked out where they thought the most appropriate guesswork was on what the shortage would look like. Worst case scenario, we're at 121,000, like I said, and best case scenario around the 42,000 mark. So most of the numbers that they were going off on was here. So we're going to stick with the worst case scenario. In the red, this is where our first year, our newest classes of medical students are going to start entering the workforce out in 2025, when the shortage of physicians is already 90,000. Well, if we're talking about this provider shortage with all of the physician burnout, we're setting these students up for failure if they're going to be coming into an environment where they're already behind before they even get started on the first day of work. Now, 2025 is when they're going to start entering, and it's going to expand all the way on past 2030, depending on their specialty. One of the things that the AMC worked into their data was expanding graduate medical education. They think that with their data, or with this expansion, with some federal funding, that they could further increase the number of physicians by over 30,000 by the year 2030. Well, quick math, that's still about 90,000 shortage. So what are we going to do about that? Well, here's my little plug. This little line right here, when the shortage is around the 51,000 mark, that's where PAs and nurse practitioners are going to start entering the workforce, and then every single year after that. So what's the other data that the AMC looked at? At the top, so first they broke it down by demand scenarios in the solid lines, and in the hashed lines, these are the supply scenarios. Supply, things that would factor into the supply of physicians, and then what would factor into the demand for physicians. Briefly, at the top, with managed care programs that patients are starting to fall under would significantly increase the demand for physicians. Demand status quo, that's looking at the number of insured patients currently looking at the Affordable Care Act, because that's the only insurance program that we really have that we know about at the moment. Demand with demographics, with our aging population, the majority going to be over the age of 65 by in a few years. They're going to be putting increased demand on our market. Retail clinics, places like Walgreens and CVS, they're actually going to decrease the demand on physicians for those services that they can have brief acute care visits and not a significant amount of follow-up. Population health here in the pink, that's looking at trying to meet healthcare goals with things like hypertension, diabetes, obesity. We're going to come back in just a moment to this demand scenario with the moderate use and high use of APPs. Under supply is whether physicians are going to be able to retire 2 years earlier. 2 years later. It really has a decent help, or decently helps the curve. Supply with GME expansion, like we already talked about. Supply status quo, that's the current rate in which physicians are entering the workforce. Supply with declining hours across the board. Physicians are working less hours, doesn't matter what age group. Last year, the last time they released this paper, they were looking at millennials and younger physicians and how they weren't working as much, but now it's actually extending across all age groups. And then supply with retiring 2 years earlier has a pretty detrimental effect right along with supply with declining hours. So the two lines that I would like to focus on are the demand with the moderate use of, I'm going to use APPs, PAs, and nurse practitioners all pretty interchangeably. It's all basically the same thing. And so with moderate use, it decreases the demand for physicians quite a bit from the managed care line of things. But here in this purple line, this is what we're going to focus on. This is with high use of APPs. What that means is increased utilization at the top of their scope of practice, maximizing their use, as well as increasing in their general numbers. The difference between this line here and this line here equals a decrease in 54,000 physicians. What does 54,000 physicians look like? Well, depending on their specialties and how many patients that they see in a year, that's anywhere between 16 million and 162 million patients. So it's not a small number, it's worthwhile. So APP utilization, where we are and how we can improve. So first we needed to figure out where we were here in the state of North Carolina. So two surveys were created, one for physicians and one for APPs. General demographic information was asked, practice information, and we got about 100 respondents from each side, and often the questions overlapped a little bit, so you could really kind of compare what the physicians thought versus what the APPs thought. So one of the key components that I want to discuss is scribe work. Scribe work being the kind of work that cannot be billed for by the APP. Inputting orders, general charting on behalf of the physician, things like that. So happy to report that 0 to 10% reported within this range, or excuse me, the majority reported within the 0 to 10% range. Blue being the APPs, green being the physicians. But I want you to focus on down here, the 11 to 24, 25 to 49, and 50 to 74% range. This shows you that physicians task their APPs with scribe work much more often than they realize. But what's wrong with that? If a physician can be more active, be able to see more patients, be more productive in their office, that seems like a perfectly good use of their time. Well, financial implications are what I would argue is a big driving force behind not doing that. So I'll try to make these numbers really brief. Don't ask me to remath this. I did it once and I'm not doing it again. If an APP has a salary of $100,000 per year and they are asked to do scribe work 11 to 24% of their day, that translates to $11,000 to $24,000 being spent on the purpose of scribe work. If they were to be using that time to see patients in their day, CPT code 99213, Medicare billing only at 85% of the coding, and depending on proficiency, that's 2 to 8 visits a day for a year. That translates to an income of $30,000 to $121,000. That's before any sort of labs or procedures. Add that together, you get these numbers here. However, if a practice were to decide to hire a certified medical assistant, their salary average is about $36,000 nationally. The practice is still in the black, $5,000 to $109,000 per APP per year. And not to mention that this CMA has actually only performed about 2 to 4 hours of work in that day. They still have an additional 4 hours left in their day to do whatever else you need them to be doing in the practice. Next question one of the questions that were asked were about scope of practice. They were asked, are you or is your APP able to practice to the top of their licensure and scope and training? Again, the majority said yes, which is very good, but 23% of APPs reported that they weren't actually able to. The biggest reason that they reported was actually that there was restrictive hospital policy that limited their ability to do so. Some others also reported that they had practiced in other states and were able to do certain procedures they are no longer able to do when they moved to North Carolina. You could say that's a North Carolina problem, but most restrictions on scope of practice are actually established at the practice level. So the onus is on us or on the practices to make sure that they're utilizing their APPs to the top of their abilities if we want to hit that high use scenario. So what are the barriers? The physicians who had supervised APPs, about 87% of physicians reported that they had, reported that components of it were concerning to them, such as liability at 43%. However, a study by Medical Economics reported that PA and physician teams actually had less levels of medical liability than physicians alone. Next was chart co-signature at about 26%. However, the Joint Commission doesn't actually set limitations or numbers on how many charts a physician needs to co-sign for a PA or a nurse practitioner. It's again established at the practice level. Imparting clinical knowledge or teaching, 18%, review meetings, or 13%. So what are the other barriers? Well, new positions need to be created. Unfortunately, revenue data often suggests that APPs are revenue negative. This, according to my survey, said that 53% of survey respondents reported that they do not bill, or only that they bill under their APP's NPI number. Well, that makes it really difficult to track revenue and productivity on the APP's part. So that we need to be able to get past that. So what are the benefits? We already talked about 162 million patients will be affected by this. Eases the demand on 54,000 full-time physicians. The missed revenue of $5,000 to $145,000 a year per APP, and then the decreased litigation on the PAMD teams. So how do we move forward? We need to be proactive. Together, we need to approach hospital administration to move these policies forward, to not be stuck in the mud, and to really look back at what restrictions are being placed on their APPs. Resources are available with the NCAPA and the AAPA. Speak with your APP on what they think and how they think that they can help. And plan to update things like scope of practice. One size should not fit all in a team approach to care. And then plan for regular updates as their experience levels increase and they receive more training. Because overall, the onus is on all of us to be able to work together to be able to really impact the care of our patients moving forward. Thank you.